How many people routinely see kids with autism in their practice? How many people treat them with medication? How many people feel comfortable knowing when to screen and diagnose and refer kids at age 12, 18? That's good. How many people feel totally rock solid on diagnosing 18-month and 24-month-olds? No, I mean, that's why we're here. So because we're all developmentalists, I have to give you my developmental history, which is that I grew up in Dallas and went to medical school here like 400 years ago, and then went away to Connecticut and got stuck in New Haven for 25 years and just came back. And it's exciting to be back, to be part of the Autism Center. And I'm using sort of my developmental history of watching the autism clinic at Yale, which started like the Bad News Bears and then ended up like the New York Yankees. Is that okay to say in Texas? And I wouldn't say we're the Bad News Bears right now, but we're developmentally, John said off and running, I would say maybe toddlers. We're cruising around the table and we're starting. And so just the practical answers to your questions. I think people who knew about the CCB Autism Clinic at Children's? Okay. So the Crystal Cherry Ball gave like $1 million or something to start the seed money for what was to become the Autism Center about 3-4 years ago, and had a bunch of great psychologists, but it was sort of the seed. And now it's moved from the Chase Bank building, and I'm going to go into excruciating detail, into the Bass Center at UT Southwestern. And it went smoothly, just like when Darth Vader put the Millennium Falcon in the tractor beam and moved it over. So we've been there 3 or 4 months. We're actually taking referrals. We're booked out 2 or 3 months right now. So what we want to do, and this is the beginning of a conversation with you as community pediatricians, is to find mechanisms to have more dialogue directly with you and your practices, and to be able to prioritize who gets in 1 or 2 months and who can wait for 6 months. Because there's going to be a wait list. We don't like that, but there is. So who's going to need to be diagnosed quickly, and to prioritize and triage that with you. So I have some ideas about how that's going to happen. So one idea is a friend of mine, Andy, in Connecticut. I only had one friend in Connecticut, and it was Andy. He was a pediatrician, and then he decided to become a psychiatrist, so he did his residency in psychiatry, then child psychiatry. And because he couldn't keep as an attending in pediatrics on wards in his outpatient practice, they assigned him to become a supervisor at the Yale School of Nursing to keep his pediatrics appointment. He thought, oh, that's a kind of a drag. Turns out it was not a drag. Turns out it was a genius move, because Andy got to supervise a lot of nurses and nurse practitioners who would do their clinical internships at the Child Study Center at Yale, and they came out like marvelous, intelligent people. And it turns out children and families liked seeing them better than child psychiatrists. And so he would plant them in offices of pediatricians. So that's one goal that we're going to have over the next 5 years. So how many people would like to have a highly expert clinical trained psychologist come to from Autism Center, come to their practices once a month? Okay. We're going to do that. I don't know how, but we're going to do that. Was there another practical question? Our wait list, we're taking patients right now. Okay, so we're having this conversation because the geniuses at UT Southwestern who did the contracts for UT Southwestern didn't talk to the geniuses at Children's who did the contracting. So we're having conversations with the medical directors of the managed Medicaid and the non-managed Medicaid. We're working on it. We are committed to providing care for all children. I don't have the immediate answer for you right now on that, but because it's several levels above my pay grade, but we're working on that. And if we can't fix it, then we're going to have, what we want to do is create outreach to the people in places who do, like MetroCare and DARS, so that we become affiliated with them and help train their people. Okay, so these are the facts, and everyone knows this. I was joking with John and Pam, like, I give a talk like this every 4 to 6 months, and the figures change every 4 to 6 months. So it's no longer 1 in 88. 2 weeks ago, CDC released the figure, it's 1 in 50. 1 in 50 kids. And on Autism World Awareness Day on April 2nd, Jack Welch, who was the founder of Autism Speaks, he takes it very personally because his grandkid has autism. You know, the study that they did 2 years ago in Korea, it's 1 in 37. So the number is probably going to end up being somewhere between 1 in 40 and 1 in 50, which means it's super. Oh, I forgot to ask the most important question. How many people have a friend or close family member or neighbor with autism? Right, everybody. So that's the answer to whether it's increasing or not. So DSM-5, everyone knows Diagnostic Statistic Manual, it's the Bible of psychiatry. DSM-5 has changed, and really the data show that it's really, you can't parse out PDD, NOS from Asperger's, from autistic disorder, so everything is going to be called autistic disorder. So when DSM-5 drops in May, and all the CPT terminology and diagnostic codes change, that's, you know, it'll be a nightmare, but that's what we'll be doing. But it really does capture it because there are kids who are, you know, from profoundly retarded and profoundly autistic to intellectually gifted, but socially very, very impaired. And we see a lot of those like in the graduate school at Southwestern. And that was not intended as a laugh line. In like the math department at Yale, which was right across from my office, you could just diagnose them in the parking lot. So the two major things about autism, to the great expert Dr. Seuss, Leo Kanner was the guy who first described this in the 40s. It had to do with autism. It's not a great word, but it's the word that stuck, which had to do with in yourself or social isolation and unusual behaviors and insistence on sameness. So after they've done the study after study after study, this is sort of the bipartite gathering of symptoms, social symptoms and repetitive behavior, restricted interest. So not that y'all really care, but you know, there's a lot of controversy about this, but in the long run, DSM-5 was committed to grandfathering in everyone who had a previous diagnosis of Asperger's, and the Asperger's community is up in arms about it. But there are concerns that there will be people who will not be diagnosed, but we'll have to see over the next few years. So, social communication criteria. So what does it mean when it says deficits in social, emotional reciprocity? These are people who talk about themselves a lot, talk about their interests a lot, you can't interrupt them. Deficits in nonverbal communicative behavior, these are the nonverbals. Kids who can't gesture, kids who can't, little toddlers who can't point, and we'll be showing some of those later. And difficulty in developing and maintaining relationships appropriate to developmental level. The restrictive repetitive behaviors, obviously kids who, you know, flat, no one's going to miss that, or people who are spinning in the corner. But also for higher functioning, people who have to do the same thing the same way every time, and everyone remembers Dustin Hoffman in Rain Man, you know, when he had to see Wapner and Tom Cruise didn't take him to see Wapner, and things like this. And kids who can't not talk about that latest video game and they repeat it verbatim, or all those things that you guys know. And a lot of sensory issues with kids that get routinized and repeated. So the prevalence, it seems to be going up. That's my personal view. Those views do not necessarily reflect UT Southwestern or Children's. There are a lot of reasons. Some big concern, more recent data about paternal age. So the age of the father turns out is a much under-recognized risk factor. And there are lots of other reasons. There are, you know, some recent studies about environmental factors, how close you live to a freeway, just like kids with asthma. But it does, how many people have trouble with vaccines, parents not wanting to vaccinate them? Wow. So do they not get vaccinated, or you just have to have long discussions on what happens? Is that why we had the pertussis outbreak? Dr. Obvious right here. So one of the things that we want to do at the Autism Center, and one of the things y'all ought to be thinking about, if there's one kid with autism in the family, all the other kids ought to be screened, like really screened. Because even kids who don't meet diagnostic criteria often will have social deficits and language deficits. And some of them may just be higher functioning kids on the spectrum and not so obviously diagnosed, so you ought to really screen and refer all of those kids. It's going to make our waiting list longer. Baby brothers are at a much higher risk. And if it's a multiplex family, when there's more than one kid in the family, the risk of recurrence gets up to 1 in 3. So at the Autism Center, when we do a full day evaluation, there's generally like an hour, 2-hour interview with the parent. The kiddo comes on the next day, and if it's a toddler, we do the ADOS. Did people know what the ADOS is? The Autism Diagnostic Observation Schedule. It's a semi-structured set of, it looks like you're on the floor playing with a kid, but it's a set of very specific social and communicative presses or bids, and then you see how the kid responds. And there are 20 whatever items, and it's graded and scored and algorithm. But it's the gold standard, and we have a great group of clinicians, psychologists who do it, but it's very highly specific, and it really brings out the signs of what the autism is. So the intake interview, the ADOS, psychiatric, neurologic evaluation, speech and language. So it really is, as John said, a multidisciplinary, and it takes a long day or a day and a half, and depending on the age of the kid, as well as cognitive testing and recommendations. So at the end of this long day, and we drop the A-bomb, you tell the family that the child has autism, it's often not the conversation where you want to say, time to think about family planning. But so that's one of the things that I think your role would be incredibly important, because you have the longitudinal relationship with the family and the parents to be able to talk about that. Twin studies, it used to be thought it was 90%, it's a little bit lower, but obviously twins, if one has, the likelihood of the other is very, very high. So the early warning signs, it's a lot easier to see stuff that's there, like flapping and stuff, than the things that aren't there, like protodeclarative pointing and eye contact and reciprocity. So I think this is one of the reasons that we think it gets missed, which is why the MCHAT is so important for you all to do at 18 and 24 months and to follow up with them. So the red flags, independent of stuff like motor delays and language delays, no big smiles, no babbling and cooing in reciprocal relationship with the mom or dad, particularly no babbling by 12 months. Kids, even who are severely language impaired, can still point and go, and make some sound that the parent will know means they want their bottle. No words by 16 months, and no 2-word meaningful phrases. So this is, a lot of parents will say, oh yeah, my kid does that, but they don't. So that's why it's really important when you do the MCHAT to have an opportunity to do an MCHAT follow-up interview and to actually be able to engage the child yourself, or to have one of the clinicians in your office do it. And we'd be delighted to set up a system of training people to do that. I don't know how, but that's one of the most important things, because y'all will be the most important, first screening step for the parents at an early age, because they have to come see you. They're going to come see you when the kid has an ear infection or their well baby follow-up. Again, I apologize for the voice. So this is the MCHAT, and all of y'all know it. Do they take interest in children? Do they use their body to point? Do they imitate you? And you have busy practices. The parents go, yeah, they do that. And I've seen it happen with close relatives where they say, yeah, it happens, and it's not. So take the time to push on the parents. So the chat office MD interaction, and you can Google this, about what you can do in the office in 5 or 10 minutes to kind of operationalize what the MCHAT checklist screens for. Get the child's attention, then point it across at the room. In the ADOS, we use like a bunny rabbit that like hops on its own. Oh, look. See if the child follows your voice or gaze, or then point. And can the child engage? It's called joint attention, which is a huge thing. The failure of joint attention in autism. Or in your office, show me the light. Where's the light? And you can tell if the kid's looking at the light, because John was talking about eye contact. We're trained as social animals to be able to see what other people are seeing, and then we infer what they're thinking when we look at their face or what they're feeling. And kids with autism don't do that. And so it's a big red flag. So it's not just eye contact with you or mom, but also eye contact following intention. Firstsigns.org is a great educational site to look up this stuff. And the parent interview of each MChat item, you can follow up sort of interaction to kind of operationalize what the... some people are thinking about screening even younger at 1 year of age, like Ami Quinn in Atlanta. And you can use the CSBS, the Communication Symbolic Behavior Scales. It's a developmental profile infantile checklist. And it's a screener. It's not a diagnostic tool, but when kids fail it, then send them our way. Even 12-month-olds, if you're concerned about them, you can send them to us, because even though we might not 100% be able to give reliable diagnosis at age 12, we will certainly be able to give a probabilistic assessment and have the child begin to engage in services. So it's not too young to be worried. And like most, the great thing about pediatrics is most of the kids are healthy, most of them are resilient, and most of them learn to walk, and most of them learn to talk and read and stuff. But this is the one time where if there's a worry, sooner is better, because these kids won't learn to talk and they won't learn to get eye contact unless we intervene very, very early. And early intervention really works. And there are lots of programs. John was talking about applied behavior analysis that Tessa does in our day treatment program, the early Denver model. So there are lots of really important interventions for kids. And 12 months is not too young. Again, it's easy to miss because if you're a first-time parent, you don't notice the kid's not pointing. They rolled over on time, they're walking on time, their language is a little delayed, but you don't think about the kid runs across the room and brings you the bunny rabbit and says, oh, bunny's sick. When kids don't do that, parents don't know. And sometimes we don't know either, because if we're busy and they have an ear infection, we're not clicked in. So now I'm going to see if I can... W.C. Fields said, never work with children or animals because they always steal the show. But here I'm glad for them to steal the show. And Pam, tell me if I'm using yours, because I don't want to. So, okay. Here's a typical kiddo. So she shows him the walk, and then he imitates. So that's imitation. He looks at her. He gives it to her. And here's a kid, red flag. He's interested in it. He's banging it. He may be imitating. He's not looking at his mom. He's not looking at the examiner. He's not lifting to show. He's not sharing. So mom's looking. She's trying to engage him. He's kind of interested. He's like... So it's stuff like that. It looks subtle, but when you've seen hundreds and hundreds of kids, that stands out like a red flag for us. 15-month-old. Oh. He looks up at the examiner. He reaches to mommy. He's like, lady, get that away from me. That's weird. And he's like, I'm thinking about it. Okay. It's kind of weird, but... There you go. So when you do hundreds of these, and then it's just like red flag. Dad doesn't look happy either. He's interested. He's thinking. He's listening. So a lot of anxious kids will bring something in the office with them, but he gets anxious and he kind of spins the wheels. He's not looking at the examiner or dad. Uh-oh. No one messes with the truck. He's just not engaged in the interaction. He's just doing his own thing. Again, this is the rock star. The bubble game, which we use in the ADOS to see if the kid will request or indicate pleasure.
Oh! No, wait. One more. Oh, you got it. Very nice. There you go. There we go. Let mama open. Give it to mama. Give it to mama. Yeah.
There's no...
Yeah.
It's just great watching your responses, right? Because we're all wired socially, and we enjoy him, and he's enjoying the interaction, and he doesn't have words, but you know absolutely what that kid wants and what he's saying, even though he's just going, ah. It's terrible to be paid to go to work and do this all day, by the way. He's looking. He's interested. Can he put it together to make a request? Not clear. The examiner's really trying to draw him out. She's getting down in his face. So is that a request?
Cheerios.
This kid is on the spectrum.
Not quite. Thank goodness. You want lower? Okay. Understands that really clearly. 1, 2. More Cheerios.
So he can request, but there are no words. There's really not much eye contact.
What?
He didn't even say anything.
No, they're not.
Dad's a good
Lower.
diagnostician.
Pat to let me know. You know, he's not using his word. Shake. Maybe Mimi will give you more.
You want Mimi to help you? Ethan, give it to Mimi if you want me to help you open it.
That's a pretty complex sentence for a little kid.
You want me to help you open it?
What would you say, Pam? What would you tell the mom to say?
Want more?
And we'll just do a little repetitive language, and then. So this is something that the parents might miss because they think their child's using language when they use it over and over. He looks at her. What's that? So he's learned to ask a question, and it's probably routinized because he's learned the language, and he probably has rehearsed it in picture books. What's that? What's that? What's that? But that's the extent of his. Yeah, he's going to say "What's that?" about 1 million times. And this is at an older age. Same thing, different age.
What is this? You know what? I think it goes with this. Should I fix it? Yeah.
But we're going to move along. So, but that's, you can actually get the DVD of all these things from Autism Speak. So you just log in yourself. It's great to watch and just to remind yourself of what these different things look like at different ages, and it's great for your staff. So medications, how many people feel comfortable prescribing like stimulants for kids on the spectrum? So medications, the problem with medications is not that they don't work, is that they do, and that they have a lot of side effects. So most of us who become child psychiatrists, you know, the dream was not to grow up to drug America's children. But what you find is that these kids sometimes develop very interfering behaviors, not just self-injurious behavior and behavior to others, but a tremendous inability to focus, tremendous anxiety, tremendous difficulty with mood regulation and self-regulation that's present even at a very early age, and gets exacerbated when there's disruption in caregivers like foster care children. So there probably is a crisis of medication in foster care children, but the problem is having treated a lot of foster kids, is that they're very behaviorally dysregulated, and some of them are on the spectrum too. So what I tell parents is that medication comes last. Identification and diagnosis comes first, and then creating an appropriate behavioral and educational program, and to make sure they're getting the full panoply of services from their school, if they're 3 and up, or under 3, from 0 to 3, early intervention, and then community support and family support. And until kids have an appropriate educational intervention, you really can't make an appropriate assessment of their behaviors, because, as you know, kids with autism disorders are famously unable to adapt to novel or difficult environments. And you can take a kid who looks very behaviorally dysregulated in one classroom setting and put them in an appropriate setting with behavioral supports, and they look wonderful. So one of the things that I try to make myself remember when parents report a big change in behavior or behavioral difficulty is what's changed in the kid's life, rather than immediately going to change the medicine, increase the medicine, or start medicine. Is that when kids' emotional behavioral needs are being met by the adults around them, and their difficulty in adapting to the environment is programmed for, they do much better. Okay, so I'm off the soapbox now. The only 2 medications approved are risperidone, Risperdal, and aripiprazole, Abilify. Do people prescribe those? Some? So these are atypical antipsychotics, and their side effect profile is much more favorable than the older antipsychotics, despite what the recent studies show. But the issue with these 2, as you know, is weight gain and metabolic concerns. All the other medicines, like most of the things in child psychiatry, are prescribed off-label, which is sort of the standard of care in child psychiatry. And importantly, all the research done on these medications shows that parent training and parent support and behavioral supports done in combination with medication make the biggest difference. So it's always important to be thinking about it's never a pill alone. So risperidone, the indications are irritability, is the official word, in self-injurious behavior. Side effects: sedation, weight gain, metabolic syndrome, and you really do have to monitor blood tests in these kids, you know, to make sure their blood glucose is okay and their lipids are okay. And it's, as you know, it's really easy to get blood tests every 3 to 5 months on kids period, and then kids on the spectrum. Certainly a number of patients I have to have general anesthesia just to have their teeth cleaned and checked, so it's a big problem. Abilify or aripiprazole, same indications, slightly different side effects, more restlessness, akathisia, and esophageal dysfunction. It's more prolactin neutral, which is probably a benefit. The Prozac family of medicines, the SSRIs, were thought to work, but all the studies done in prepubertal kids indicate that not only do they not work, but they make kids worse. There are exceptions to this. So this is back to what John was talking about in hyperserotonemia, that there's probably a specific reason, not just metabolic and cytochrome P450, but there's probably a brain-related serotonin reason why kids do worse on these medications. As youngsters, they can be helpful in adolescents and adults. The central alpha agonists, guanfacine and clonidine, have gotten a new lease on life, as Intuniv and Capvey. and we used them at the tick clinic at Yale for many, many years. They're very helpful for that, and everyone knows that. But it actually, guanfacine and clonidine do help hyperactivity, impulsivity, and aggressive behaviors. But they actually also, surprisingly to me, since they're so sedating, they actually do help executive functioning, particularly guanfacine, although they're really second line compared to the stimulants. The beneficial side effect of sedation obviously can be used because kids with autism have a lot of sleep problems. And the guy who developed the drug, he was at this table at the Child Psychiatry Convention. I said, Bob, you're in front of the intuitive table. Why? He goes, because I invented it, Preston. And so he's made the point that give it at night. It's metabolized better, it's more effective, and you guys probably already... How many people use Intuitive or Cafe? Okay, so you know all about that. Sometimes the anticonvulsants can have mood-stabilizing properties, and they're indicated in psychiatry for bipolar disorder. And everyone knows about the limictal rash. Okay, so here's the controversy. I put this slide in, and one of my colleagues said, no, you're not talking about complementary medicine. So how many people think their patients might sometimes use complementary alternative medication? Right, so despite the fact that I had this slide here, and I always tell, ask your patients. I was treating a medical student the other day, and they said, oh, is this going to interact? And he pulled out a list of the 15 things he was taking. I was just treating him for depression. So Autism Speaks, knowing that people are on, yeah, I got 5 minutes, thanks, is the approach both from the child psychiatry, the RUP study, the research unit on pediatric psychopharm, and Autism Speaks is investigate the disorders that are most impairing and investigate the disorders that are most prevalent. And because these kids are going to be on medicine anyway, and we need to create a research database for evidence-based medicine. So only someone as reputable as Bob Hendren at University of California, San Francisco is doing the studies, the safe, sometimes double-blind, sometimes not, funded by Autism Speaks on some of this funky stuff. Melatonin's been used for years in kids for sleep disorders, including at Boston Children's, and there's evidence for kids with developmental disability that it's safe to use, 2 to 6 milligrams, and parents generally, even before they come to see me, their kids are on this. Omega-3, there's some evidence in autism that it might be helpful in sort of routine dosage-free fatty acids, and there's more research going on in ADHD on this. And it's certainly one of the situations when if it's done in reasonable dosage, it's not going to hurt. And if the parents feel better giving it, there's that. There's some studies going on about B12 and magnesium. A lot of kids end up on probiotics. How many people on the gluten-free diet in your practices? Really? Not. So parents swear by this, and there are no really great studies. It's hard to do a study on diet because you don't know what the kid's actually eating at home. You can do blood tests or urine tests sometimes. But Bob actually did a trial on hyperbaric oxygen. It doesn't work, but there are going to be families who will do stuff like this. So my recommendation, so in psychiatry, right, you hear things that they won't tell anyone else. So I'll be seeing the kid and the family, and they'll say, but please don't tell my pediatrician because they'll fire me from their practice if I tell them that we're doing. So I always recommend have an open conversation with the parents. Tell them I know you're going to go out and do all this stuff, so just tell me what you're doing, just so I'm aware, so that if I prescribe an antibiotic or they have a side effect and they end up in the emergency room, so I'll actually know what they're doing to create an open dialogue with the parents.